Hello everyone, my name is Matthew Carby, and along with Paul Fallu, who will also be a big part of this presentation, and Dr. Robert Haig, we are the creators of this presentation called Acute Stress Management Techniques for the Healthcare Provider. And what we can see in the background here is something that really sums up the presentation itself, and it's a physician in the background that's kind of holding his head after this acute reaction or after this acute event happened, leading to some kind of stress event. And what's really important to recognize here is that it's just the physician in that room right now. And we don't see anyone else who is involved with this trauma, nurses, paramedics, janitors, etc., etc. And they're also people that we have to be worried about in this case, especially when it comes to developing acute stress disorder. And that when we're talking about this presentation in general, is that it entails not just the physicians, but everyone who is a part of that team. So I just believe that's a very good takeaway point on that to remember when we're going forward. Okay, so just a little bit about myself before we begin the actual presentation. My name is Matthew Carby once again, and I got my Bachelor of Neuroscience from the University of Lethbridge, Alberta, and did my EMT paramedic training in Calgary, which is just north of there. I also did my flight and critical care paramedic training through the University of Florida and the University of Maryland and Johns Hopkins Hospital, their pediatric divisions. Subspecialties in those listed, and I'm currently a second-year medical student at St. George's University.
So just to kind of sum the slide, and the reason why I included it is because I full-heartedly believe that this type of lecture requires someone who has overcome a type of trauma. And that trauma doesn't necessarily need to be related to the medical environment. However, it does require that those steps, knowing those steps of acute stress disorder and kind of the signs and symptoms that develop from them in order to successfully convey how this presentation should be given. And whether or not you developed acute stress disorder and or PTSD, both of those individuals would be very credentialed to present this, giving different aspects and different kind of viewpoints on how to overcome these and or get ready to deal with it if it is inevitable, as Paul Fallu will explain later.
So just to introduce these four topics before we delve into the actual cases that we're going to be starting with, we have four kind of domains of critical incident stress reactions. And those four domains are the physical, cognitive, emotional, and behavioral domains. So if we start at the top three, the physical, cognitive, and emotional, those three kind of sum up how you're going to start feeling within those few days after that event happened. So physical being that low energy and headaches, those things that you can actually feel. The cognitive being depressive signs and symptoms or anxiety, and then the emotional being any type of anger, irritability, or suppression. I believe all three of these are going to happen almost immediately after you're finished that event. And what happens is, if we don't deal with these three things before time kind of lags on, then we delve into that behavioral realm. And that behavioral realm is where we have the increased risk-taking scenarios. And to go along with this, we have suicidal ideation, which obviously in this case is a bad thing to kind of develop into. So the way I start up this presentation is, anyone who has experienced a traumatic event in the past, I would just like you to think about that traumatic event and summarize it in one simple word. So just think about that for a second. So some examples of the one word that come to my mind when we're thinking about any type of acute stress reaction and the signs and symptoms that go along with that is anger, is sadness, is just that general shock feeling that you get, that frozen state that you see that physician in the very first slide. The frozen state describes that your brain or your mental side is taking over the body and now you can't move. So the whole goal of this presentation is, when you are in that frozen state, you can't move, this acronym is hopefully going to help you get out of that state and hopefully give you a checklist. And this checklist, if for all those people that are going into medicine, we're all A-type, and that A-type is actually going to help us in this case. And to give you provide you with that checklist that's going to say, hey, I finished something. Hey, I finished another thing. If you can kind of work your way up or work your way down that paper or that check for each thing, then you start to feel better because now you've nailed off things that could have been worrisome or you might have forgotten. and we're going to start delving into the COPED acronym, which is going to be your checklist for the future. So the way that we're going to do this type of presentation is going to be by cases. We're going to present 2 cases, and we're going to give you the environment, we're going to give you the scenario that happened, and then we're going to give you the result of it and how that practitioner dealt with the scenario. And then we're going to give you the acronym to hopefully deal with or help deal with these types of situations. And then we're going to go into the second case, which you can hopefully relay on that knowledge you just learned and assist you with the acute stress reactions that you may get in the future. Just a warning before we start, some of these cases may be emotionally disturbing. They're my own personal cases from the past, and these are ones that I've overcome, developing acute stress, but not developing post-traumatic stress disorder. And if you are squeamish or you are any type of disturbed by these types of cases, then please just stop and continue on when you are ready. So the first case, you can see in the yellow there, and then you can see the white as well. The yellow is going to be the background to the case. I'm going to give you the background, and then what I want you to do is, with the white font, I want you to step into the shoes of the practitioner. Give yourself that first-person perspective and really understand the emotions that went along with this type of call and everything that they were feeling that may have resulted and did result in acute stress. So let's get started. You are a team consisting of a physician and a paramedic. You are dealing with a 1-year-old male being transported from Bermuda to Boston for cardiothoracic surgery due to an exacerbation of a previously diagnosed heart condition. And what happened was this heart condition actually led to a very fast heart rate or unstable supraventricular tachycardia, which resulted in a cardiac arrest event. So they lost their pulse. And then the practitioners that were dealing with them in Bermuda actually had a return of spontaneous circulation, which is a return of a pulse. So you arrive on scene. Patient is intubated and on a ventilator with 2 inotropes or medications to keep that heart rate or to keep the blood pressure up. And we also have adenosine drawn up just in case that supraventricular tachycardia heart rate returns. And then defibrillator pads are also placed just in case of another cardiac arrest. So now delve into the shoes of that practitioner and see this from a first-person perspective. So at 40,000 feet and halfway through transport, the patient goes into cardiac arrest once again. Patient is defibrillated with no avail. CPR is being completed adequately. You are doing great compressions. You are controlling the airway very well. No medications that you were giving seem to be reversing this cardiac arrest. These medications include amiodarone, procainamide, and epinephrine. You both continue CPR for 4 hours until arrival at the receiving hospital, and 1 hour later, the patient's pulse actually returns. Unfortunately, with the amount of time in cardiac arrest, and despite adequate CPR and appropriate interventions, the patient now has no brain function. The patient is being maintained by a ventilator, and a few days later, the family decided to remove that ventilator and all life support, and the patient died as a result. So I just really want you to think about what emotions come to mind when you think of this traumatic event, and are there any triggers that may lead to acute stress in this case? So think about one word that would go along with this, and just think about that one word. The second question being, how would you personally deal with the outcome of this case? And that being, what would you do if you were starting to develop the signs and symptoms of acute stress? Remembering that acute stress disorder is diagnosed on that 3rd day all the way up until a month after the event. So you are now developing those signs and symptoms of acute stress. What would you do? How would you deal with it? And just take another few seconds to think about that. Okay, so now you've had time to think about one word that comes to mind after this case and how you would personally deal with it. And just to add to this as well, the more and more times that you deal with these situations and they lead to these acute stress signs and symptoms developing and you think you get over it, but you don't deal with it properly, I describe it as adding a chain to your back. And attached to that chain is a 40, 50, 60-pound rock. So you can see that every type of event that you go through, or every event that you go through that you do not deal with properly, you add another chain to your back, and another chain, and another chain. And what you can see is that this weight gets so overwhelming that eventually you're going to break, and you're not going to be able to carry that weight. And that is how I describe post-traumatic stress disorder. So how I would like to convey dealing with acute stress and the stress management that goes along with it is the COPED acronym. And the COPED acronym can be visualized kind of from a bottom-up perspective. And the way that Paul Fallu kind of describes this is you're putting a mirror up to your own self, and you're really seeing how you look in that mirror. And if you put up a mirror to the COPED acronym, you can really see how you'd be dealing with this from a bottom-up perspective. And the whole goal of this is to hopefully attempt to deal with the shock-like mental state, that frozen state we were talking about, before the third day occurs. Because remember, that third day is when we are technically diagnosed with this acute stress disorder. So tackling this acronym, as we said, bottom up, we're going to start with debriefing. And debriefing happens immediately after the event happens. The immediate team that you had involved with this call are all going to meet into a room, and you're going to talk about what just happened. You're going to talk about the good, you're going to talk about the bad, and you're going to talk about everything that went along with it. What you're not going to do is point the finger, and you are not going to put blame on anyone. I believe that is a very key thing with debriefing, because if you are starting to blame anyone for this event, then you are not debriefing, and that is not the proper way to do this procedure. So debriefing, that takes place within the first few hours, and that, again, that's just the immediate team that was involved with that. Diffusing actually takes place within the first few days. So on the second day would be a great example. And what that is, it's almost like a debriefing on steroids, where you have your immediate team that was involved with this, but now you start to integrate outside sources, such as counselors, psychiatrists, outside physicians who can give you another perspective on this call. And what's great about that is it gave you time to think about what actually happened. And the way I like to describe this is when you finish that really hard test, you walk out of that room, you're almost in shock. And a shock-like state makes you forget everything. You go home, you relax for a while, you start thinking about it, and now you can actually remember some of those questions that were on that test. And now you start looking and flipping through your pages, and you're like, beep, right? Got it wrong. Anyways, when we're talking about this process in general, it gave you time to think about what actually happened in this event. Things that you want to bring up that are concerns, or things that you think actually went really well, now you can bring up during diffusing. Moving on to the E, experience as a result of this tragedy. So can we grasp any knowledge from this call? Dealing with the tetralogy of Fallot, for all those that know, is a very complicated diagnosis. And when you are in the pre-hospital environment, specifically in a plane in this case, it's almost impossible to deal with this case. So realizing that maybe, hey, there was another medication we could have given, or there was another intervention that we could have done to maybe sway the cardiac arrest, and we've actually found it during debriefing and diffusing, then you've actually grasped some knowledge and some experience from this call, and it wasn't all for nothing. And I believe that's really important to kind of check off your list, is that, okay, if I have this patient again in the future, I know I'll remember this. Okay. P, being personal stress management techniques. These are the things that you do yourself all the time. After that really hard test, you go home and you swear for a few hours, etc., but then you go and game it, or you go play your guitar, or you do whatever you do to make yourself feel better. The problem is, when you are in this acute stress state, or this frozen state, you tend to forget about the personal stress management techniques you already have. So you go home and you cry, which is actually not a bad thing, and we're going to talk about right away. But you forget about it. And what this acronym is helping you do is to remember that you actually have things that you already do to make yourself feel better. Okay. O, being outcome was out of your control, especially in this case that we just dealt with, where you're in a plane. It is two of you, plus the pilots who can't help you because they're hopefully flying a plane. You're dealing with a pediatric cardiac arrest, which in itself should be 8, 10, 12 people handling this type of situation. So again, this is almost an impossible situation you've been thrown into, and realizing that it was completely out of your control. Caveat to this is if there was malice introduced into this or negligence, this acronym will not work for you. However, if you tried your damn hardest to save this patient's life and it still resulted in a bad outcome, just realize that it really was out of your control in that case. To go along with this, medical students that enter into their clinical years or residency, especially as interns, is you go in with a certain mindset. And the mindset being kind of two opposite ends of a spectrum, and they're very polar opposites. At one polar end, on my right-hand side, we have the people that are very new, very young, have never dealt with patients before, and they go into these situations expecting to save everyone's life. And in reality, we can't look at it from that perspective, because the natural course of life is that everyone dies. So when you walk into your first pediatric cardiac arrest or your first adult cardiac arrest, realize that people are going to die. You cannot save everyone. And at the other polar opposite end, we have the people that have been in this industry for so long, in the medical industry for so long, that they're already jaded. And they're jaded against the patients that come in and can't really step into the shoes of the patient and feel how they're feeling, having empathy for them. So the two polar opposite ends, you can see that one doesn't really outrule the other, but we need to delve into our clinical environments kind of meeting in the middle. And that's the way that the mindset should be when you're heading into your first day of clinicals or your first day of residency, etc. Realize that you can't save everyone's life, but we can try our damn hardest. So I just want you to recall what the COPED acronym actually is, and just try and recite it in your head, and then we'll move on to the next slide. Okay, so we've dealt with that first case. We've kind of gone through that together, and we've ran through the COPED acronym. COPED, remembering, standing for counselor psychiatrist, outcome was out of your control, personal stress management techniques, experience as a result of this tragedy, and debriefing and diffusing, and then integrating the mindset into the outcome was out of your control. Let's move on to the next case, which is a little bit less benign than the last case. So again, just a little bit of a warning before we move on, that this case can be a little bit mentally harming, and that if you are disturbed by this, just please stop the presentation and move on whenever you are ready. So here's the setting you're in. You're actually in an ambulance, okay? And then we'll move to the next slide for the background. Okay, exactly the same as last time. The yellow is the background, the white is you stepping into the shoes of the practitioner. So here's your background. You are a team consisting of an EMT and a paramedic, responding to a deep woods call in an ambulance for a 2-year-old female who was abducted after her father was murdered earlier that day. Okay, step into the shoes of the practitioner and just listen to my voice. On arrival, a team of forestry rangers guides you to the site where the girl is located. Although you cannot see much in the dark because it's nighttime, you can hear the faint screaming of a child in the distance. You travel approximately 1 mile further and find rangers have subdued the suspect and are completing resuscitation on a 2-year-old girl. She's been incinerated from head to toe, with the majority of blistering over the face and torso. You take over and complete advanced life support on the patient with intubation, ventilation, and pharmacological interventions. You do this for 25 minutes with no return spontaneous circulation. You contact the physician via satellite phone, who determines that resuscitation can be halted based on the report you've just given, and time of death can be called. So you call that time of death and allow the police to conduct their investigation. The police approach you about 15 minutes later and have told you that cannibalism was also an aspect of this call. So now what I want you to do is, I want you to think about that one word once again, and what emotions come to mind when you are thinking about this. I'm going to give you a few seconds. So, to give you my side of things, the emotions that came to my mind, especially immediately after this call, is anger. And we can all relate to this, that the very unnatural event of a pediatric dying is now coupled with the aspect of cannibalism, which just is even more unnatural. How can you expect to deal with something like this? How can you properly avoid acute stress, let alone PTSD, in a situation like this? So really think about that one word you had and just try and bring it forward as we move through the COPED diagram. What do you consider COPED in the situation? A little caveat again is if you already have a way of dealing with things, if you were a practitioner in the past and you had some other acronym you used or some other method of dealing with these situations and you do not have post-traumatic stress disorder, then please continue to use what you have used in the past. COPED acronym is there for those who have never had any experience in the past or are looking for another method of dealing with these types of events. Another question is the statement, is crying okay? And a lot of the times when I'm doing this presentation, everyone shouts out, no, it's not okay to cry in this situation, until I give you the aspect that, okay, the family has now approached you and has asked you what happened to their daughter, and they are crying, they are bawling their face off, and you are sitting there like a rock. Is that what the family needs right now? Does the family need detachment? And my answer to that is no. And what I would like to convey is that crying is okay. It's okay to shed a tear once in a while with the family to show that you are an actual human being, that you actually care about this patient. Do not bawl your face off in front of the family because this is about the family right now, not about you. However, this is another method of you dealing with things. You're releasing your emotions in some sense by crying. Okay? And it's showing the family that you care about this patient. Okay. Do we deal with the death of a pediatric versus an adult differently? And my answer to that, from my own perspective, is definitely yes. The reason being, as we brought up previously, is that pediatric deaths versus adults are unnatural. We are not meant to see a pediatric die. We're not meant to see a little one die, unless it was unfortunately planned from the start. However, in adults, we know that there is a continuum. We know that every one of us is going to die at some point. However, in the pediatric realm, it's completely unnatural to deal with that because it was not their time. Another big statement I would like to convey is that what we do as a team of healthcare practitioners is what's going to help avoid acute stress disorder and post-traumatic stress disorder in the end, and reduce those rates of burnout. The very beginning slide with the physician's holding his head. Remember that he is not the only one involved in the situation. You must deal with this as a team. That is going to help avoid you pointing the finger at anyone. That is going to help you deal with the situation because now it's just not you by yourself, but it is everyone who is in the grieving process. And I would rather stand beside my partner than I would by myself. And now what we're going to do is we're going to transition to Paul Fallu, who is going to give a little bit more of an explanation on PTSD. Okay, so here's Paul Fallu.
Thanks, Matt. So, at times it seems that PTSD becomes this enemy to be avoided. I tend to view it more as a continuum where you have an event, you develop acute stress, and after 30 days, if you're still having symptoms, it technically becomes PTSD. despite using any tool, despite the best efforts, the event could be so catastrophic that you're going to develop PTSD. And it's our hope that you're able to recognize it and seek care sooner. Like with many things in medicine, it is easier to treat things in an early stage than in a late or chronic stage. COPED is a tool, and Matt has already explained how this works. But if you have a tool that's working for you, that's fantastic. But like any good toolbox, having only one tool may not be adequate. If I only have a hammer and it works most of the time, all I'm doing is hitting nails. If I have a developed toolbox, I have socket wrenches, screwdrivers, drills, you name it, it's there. I can fix the car. You're entering into healthcare. For an average person, they might have one event or none in their lifetime. By choosing to do what we do, you're going to have many, many events. Cumulative damage can occur. Using COPED helps to minimize that. Burnout is a problem in our profession, not limited to just us. But I think the last AMA guidelines, somewhere around 49 to 50% of physicians are burning out in certain specialties, like emergency medicine, critical care. A friend of mine describes PTSD as a normal reaction to an abnormal situation. In almost any other aspect of life, you can practice something and get better at it. If you want to run faster, you practice running. If you want to learn how to do a double under with a jump rope, you keep practicing it and practicing it and practicing it. How does one practice dealing with stress? Do you go out and just keep inflicting stress on yourself and see if you figure it out? And my answer is no. Using tools, using your friends, using professionals, but recognizing that you cannot do it alone. Healthcare providers, along with military and many, many other folks, carry a stigma into seeking help. It can be a sign of weakness, it can be a sign of failure, it can be a sign of not being strong enough. And that's false. If you have high blood pressure and you're an internist, you can manage most high blood pressure, but you need to sometimes call the cardiologist. If you're an internist and you've diagnosed appendicitis, you need to call the surgeon. Nobody magically appears until you call them. Seeking help is the same thing. No one may see the inside. No one may see the pain. We are all masters at hiding it. You know. COPED helps us to solve that problem ahead of time. Like preventive maintenance on a vehicle, it helps us to figure things out. PTSD is something that can develop, and it still might develop. But using this can minimize that. Thanks, Matt, for letting me have a few minutes. Understand that PTSD in and of itself is an entire lecture of its own. It's books written about it. But see it in the light that it's on a continuum. And that this is a tool to help prevent, but not an absolute. We can, in healthcare, follow every order. We can do everything perfectly and still have a bad outcome. It is no less with this. I still think it's a pretty good system. I use it. So that being said, thank you, Matt, and I will turn it back to you.
Okay, thank you, Paul. So we can see that there are a few different perspectives on PTSD itself, and what you'll actually recognize right now is that we've only really covered OP, ED, and not the actual C. And the reason why we did that is because your last effort to try and help you with this grieving process, with this acute stress that you're going through right now, is to consider a counselor and a psychiatrist. And when I say that, I do not say that lightly, because because there is a very big stigma out there that going and seeing and seeking help for these types of conditions is looked down upon, that you are not strong enough to deal with these types of events and that you shouldn't be in the industry if you can't do that. And I am here to tell you that that is completely false. You seek a counselor if you feel that it is needed. And if the counselor cannot give you another perspective on things and it isn't helping, then it's time to go and see a psychiatrist. And I can tell you for a fact, I have seen a psychiatrist before, I have seen counselors before, and I do not feel one bit bad about it. I do not feel I am any less strong than anyone else that has gone through any of these types of events. So lastly, whose fault is it in the end? And really remembering that COPED actually helps with stating that it is no one's fault. And I've highlighted this in green because coming back to that team aspect, that you cannot point the finger if you've dealt with this as a team. This was a team thing. You're going to grow as a team as a result of this event, and you're going to grow individually as a result of this event. So realizing that it is no one's fault in the end. Of course, pending malice and negligence were not introduced. So in conclusion, as I've mentioned already, is that if you do not have a method of dealing with this acute stress, after that third day comes around and you're still experiencing those signs and symptoms of acute stress, that acute stress disorder gets diagnosed. And it lasts all the way up until a month after that event. After a month of going through acute stress disorder, this transitions into the diagnosis of PTSD. So the whole goal of this acronym, reiterating it, is that we are going through the entire COPED acronym before that third day comes around. And I really want to hammer that on the head really hard, that we want to deal with this before there's an actual diagnosis happening. I am not saying acute stress disorder, I'm not saying if you get diagnosed with acute stress disorder that you are any weaker than the rest of us. Exactly like Paul said, sometimes this is inevitable, and sometimes you cannot prevent these events from leading to the disorders. However, we can recognize that it's coming and trying to deal with it as soon as we can. Whatever your techniques, again, this is just a recommendation, use them to its full extent. Really try and benefit all of the resources that are given to you. Realize that there are psychiatrists, there are counselors, and whatever your hospital that you're at allows you to do or has as resources, then please utilize them. And realizing that you are not a stronger person if you do not seek help. So any questions that you guys have, or any stories that you want to share, please email me at mcarby@sgu.edu. I would like to thank quite a few people. First of all, my previous position as a flight paramedic through Latitude Aeromedical for supporting this endeavor. The SGU Emergency Medicine Club for, again, supporting this endeavor. And St. George's University as a whole for now allowing this acronym to be presented to the clinical students and the basic science students as a whole. So now that everyone can have access to an acute stress management technique in avoiding acute stress disorder and post-traumatic stress disorder. There's a brief survey if you do have time. This is not mandatory by any means. However, if you can take the time to fill this out, it just strengthens the acronym as a whole and the statistics that go along with it. I would also like to thank Ryan Kelly, who is a second-year medical student, for completing this audio-video recording. Some of us are very handicapped when it comes to technology, so I would like to thank him, who is a master in it, for completing this video. Other people I would like to thank, again, is Paul Fallu for adding the aspect of PTSD, and that it is not always this bad thing that is approaching, but realizing that we can grasp that it is coming before it does. I'd also like to thank Dr. Barbara Landon for integrating the aspect of mindset into this acronym. and Dr. Robert Haig for really slingshotting this idea right from the get-go when I approached him with it a year and a half ago. Here are the citations, and if you have any questions, again, please do not hesitate to email me. Thank you very much for watching, and I wish you all the best in your rotations and your semesters ahead.